Good morning, everybody. My lecture today is about PVC, Life in a Box. First of all, I want to thank Professor Dr. Mirvat Abul Maati, Mother of EP and President of AFRA, for giving me the chance to share this lecture with you. Also, I want to thank my dear colleague Dr. Muhammad Al-Musallami for preparing this presentation. First of all, we should have a comprehensive anatomic approach for the prediction of the site of origin of PVCs. As we see here, this is a diagram of the heart showing the outflow tract and the right ventricle and the left ventricle. When PVCs has an inferior axis and negative lead one, so it most probably come from the left side of the outflow tract or the left side of the heart, and differential diagnosis of site of origin of PVCs in this situation is from anterior RVOT, left coronary cusp, LV summit, aortomitral continuity, superior mitral valve, or left anterior fascicle or anterior papillary muscle. When PVCs has also inferior axis but positive lead one, so it is mostly coming from posterior RVOT or right coronary cusp, parahesian or superior tricuspid valve. When PVCs has an superior axis and right bundle branch morphology, so it mostly come from inferior mitral valve or left posterior fascicle or posterior papillary muscle. When it has a superior axis and left bundle branch block morphology, so it is mostly coming from inferior tricuspid valve annulus or from crux or moderator pad. Let's go through the cases. The first case here is a 38-year-old female patient not known to be diabetic or hypertensive, complaining of palpitation, start since 1 year. ECG show sinus rhythm with frequent PVCs. Holter show PVCs burden around 29% with normal echo. As we see here, this is an ECG show PVCs coming in the form of bigeminy. With late transition, as we see here, QRS transition is at V4. PVCs also has an inferior axis and positive lead one. So our differential diagnosis here is posterior RVOT, right coronary cusp, parahesian or superior tricuspid valve. We start our procedure by insertion of a decapolar catheter into the RVOT to map the RVOT, and also here we insert the ablation catheter to map the site of earliest activation appearing on the decapolar catheter. PVCs become less frequent, so we do pace map. Then we go for mapping of the LVOT using a retrograde approach, but it was earlier at the RVOT, so we return to the RVOT and do pace mapping before ablation. We start ablation here with successful ablation of the PVCs and waiting for 45 minutes with no single PVC. Second case is a 52 years old male patient known to be ischemic cardiomyopathy with ejection fraction 36% and NIA class 1. He had a recurrent non-sustained VT. Cardiac MRI show marked myocardial scarring along LAD territory. ECG, as we see here, show almost negative QRS in all precordial lead and inferior axis 1 and AVL is almost negative, so it's most probably from anterolateral part of apical segment. We start our procedure with a Carto 3D mapping system. We insert decapolar catheter into coronary sinus, and ablation catheter through retrograde approach of the LV. We do voltage map and lead map. This hot point was at the anterolateral part of mid to apical segment. And we start ablation. Then we do programmed ventricular stimulation after ablation with induction of non-sustained VT. So we ablate again with successful termination of the BVC and no induction of non-sustained VT. Third case is a 17-year-old female patient complaining of palpitation started since 1 month. ECG show wide complex tachycardia and echo was normal. ECG here show non-sustained VT. VT here show left bundle branch morphology with transition at V3 and inferior axis and negative 1. So our differential diagnosis is anterior RVOT, left coronary cusp, LV summit, aortomitral continuity, superior mitral valve, left anterior fascicle, and anterior papillary muscle. We start our procedure as we see here with insertion of the decapolar catheter into coronary sinus, and we used to insert the decapolar catheter deeply into coronary sinus to map the area of the LV summit as we see here. We notice that CS1 and 2 show a very nice signal that was preceding the PVC on surface ECG by around 34 milliseconds. So we introduce ablation catheter through retrograde approach to the LVOT and start to map the left coronary cusp, and we found a very nice potential around 40 milliseconds before onset of QRS complex on surface ECG. So we start ablation here with successful ablation of the BVC and successful termination of VT. Waiting for 45 minutes with no single BVC or no VT, and this is ECG 4 week post ablation. Fourth case is a 55-year-old female known to be hypertensive, presented with palpitation. ECG show sinus rhythm with BVC, and BVC's burden Holter monitoring was around 29%, and echo was normal. This is ECG show also left bundle branch morphology of BVC with transition at V3, and it has inferior axis and positive negative in lead 1 and negative in AVL. So also our differential diagnosis here is anterior RVOT, left coronary cusp, LV summit, aortomitral continuity, superior mitral valve, left anterior fascicle, and anterior papillary muscle. Also we insert decapolar catheter deeply into coronary sinus and start to map VOT using ablation catheter. We start ablation here with suppression of BVC, then recur again, so we do more mapping of RVOT. We have a very nice signal, so we start ablation here with suppression of BVCs. Waiting time for around 45 milliseconds show no BVC, and this is ECG 1 month post application. Take home message: we have to revise patient age, symptom, BVC burden, echo, coronary angiography, cardiac MRI. We have to study ECG localization of BVC, and we have to do ECG by yourself. Place a decapolar catheter in coronary sinus, then move it where you want. Get venous and arterial puncture. Get an intelligent fellow to make the measurement and wait for 30 minutes at least to check for recurrence. Thank you.